Imagine this. You step into an emergency department, right? And maybe you've got, I don't know, a sprained ankle. It hurts, sure, but it's not exactly life or death.
Hmm.
You might end up waiting maybe 45 minutes. Seems pretty typical.
Yeah, unfortunately common.
But what if, in that same waiting room, someone else is showing these really subtle early signs of something serious, like sepsis maybe, or even a heart attack, and they just go unnoticed? Just because the staff are completely swamped, maybe manually sorting through cases, and that patient loses absolutely critical treatment time.
It's a real problem. That scenario isn't hypothetical at all, sadly. It's a daily challenge. That sorting process, when it's manual, can genuinely be the difference.
Okay, let's unpack this. Today, we're doing a deep dive into Triage AI agents in healthcare. And our mission really is to get a proper understanding of how these smart systems can quickly assess, classify, and direct all this incoming patient information. Basically how they're starting to revolutionize patient care.
It really is quite something. The ability to sort and prioritize information quickly, it's critical in any fast-paced setting.
Like any air traffic controller?
Exactly like that. Or a 911 dispatcher. In healthcare, it translates to making absolutely sure that the most urgent patient alerts get to the right clinician, like right now, while the more routine stuff, updates, flows somewhere less urgent. When we talk about speeding up response times or easing the burden on doctors and nurses and ultimately getting better outcomes for patients, this kind of intelligent triage, well, it's the absolute foundation.
Yeah, that contrast you drew, the sprained ankle versus maybe the hidden sepsis, it really highlights the core issues Triage AI is meant to tackle. So what are those big problems we're seeing today?
Well, you've basically nailed one of the biggest ones. It's the sheer volume, the workload on clinicians.
It's just too much information.
Way too much. Think about emergency departments. They can see hundreds of people arriving every single day, and each person generates this huge stream of data vitals, labs, notes from the doctors and nurses, everything.
Right.
And without some kind of automation, the care teams are spending precious minutes, sometimes hours, just manually wading through alerts. Sifting.
And those are minutes not spent with patients.
Precisely. Minutes they really should be spending face-to-face providing care.
And it's not just about lost time being an inconvenience, is it? There's a real risk involved. Here's where it gets really interesting. I saw a statistic. For conditions like sepsis or a heart attack, what doctors call acute myocardial infarction.
MI.
Every single hour of delay in starting treatment can push up the mortality risk by as much as 7.6%.
That's right. It's a terrifyingly steep curve.
So these early warning systems, the ones powered by Triage AI, they can flag patients who are at risk literally seconds after the data comes in. It turns that ticking clock from a threat into, well, an opportunity.
Exactly. And this is all happening against a backdrop of what we call data overload. It's immense.
How much data are we talking about?
Modern hospitals generate terabytes of data. Think about electronic health records, EHRs, all the bedside monitors, imaging machines, even the apps patients use now.
Wow, terabytes.
Yeah, and trying to review that manually, it's just not feasible to catch everything. It's incredibly easy for the human eye, even a trained one, to miss subtle little trends or those very early warning signs. Things that automated analytics, crunching through vast, complex data sets, would pick up almost instantly.
Like if the AI doesn't get tired or distracted.
Exactly. It doesn't overlook that tiny fluctuation buried in a sea of numbers.
Okay, so it's clear why these systems are needed. But, for anyone picturing some kind of mysterious black box, what's actually going on inside one of these Triage AI agents? How does it actually make that leap from raw data to a potentially life-saving decision? Let's break down the components.
Yeah, let's do that. Fundamentally, a Triage AI agent isn't magic. It's a sophisticated system, but it has distinct parts working together. First up, you've got data ingestion.
Getting the data in.
Right. Think of the agent here like a universal translator. It grabs and centralizes all the incoming information from all those different sources we mentioned, medical devices, record systems, maybe patient input from an app. And crucially, it puts it all into a consistent, structured format, makes it ready for analysis.
So it standardizes everything first.
Pretty much. Gets everything speaking the same language, you could say.
Okay, so it's like this central hub pulling everything together neatly. What happens then?
Okay, once it's ingested and organized, the data goes to the feature extractor.
Feature extractor. Sounds a bit technical.
It does, but the concept is straightforward. This part transforms the raw data into, well, meaningful attributes, relevant details. Imagine it like a detective finding clues at a scene.
Okay.
So instead of just seeing, say, a patient's temperature reading, the feature extractor might figure out the rate of change in temperature over the last hour. Or it might combine that temperature with heart rate to create a new feature that's more indicative of a problem.
So it's finding the important signals, the patterns within the raw numbers.
Exactly. Pulling out the crucial clues the AI needs to make a decision. And then you get to the assessment engine. This is really the brains of the whole operation.
This is where the triage happens.
This is it. It takes all those extracted features, those data points, and evaluates them using patterns it's learned from past data from its training. Based on that, it assigns risk levels, categorizes the case. Is it urgent, high priority, low priority?
Right.
And then built-in decision logic directs that case to the appropriate workflow. Urgent cases trigger an immediate alert sequence. Lower priority stuff gets routed for standard review later.
Okay, makes sense. It assesses the situation. And once it's made that call, how does it actually, get the word out, get that critical alert to the right person fast?
Good question. That's the job of the alert dispatch component.
Right.
This is the delivery mechanism. It sends out the notifications or assigns tasks to the correct people through the right channels. Could be a flashing alert on a nurse's station dashboard. Could be a secure message pinging a specific doctor's app. Could even be an automated trigger to start prepping an ICU bed. It's all tailored based on the priority and the type of case. Speed and getting it to the right place are everything here. And then, finally, and this is super important, there's the feedback loop.
Okay, what's that do?
This is how the system learns and gets better. It constantly monitors the cases it's handled. It records what actions were taken by the humans, measures how timely things were, how accurate the initial triage was.
So it checks its own work, essentially.
Precisely. And it feeds all those results back into the system. This helps refine the rules, tweak the algorithms, improve the models over time. It's what makes it an adaptive learning system. Every single patient interaction, every decision made, it becomes another data point that helps the whole system get smarter.
Wow, that's quite a cycle. It's constantly refining itself based on real-world results.
That's the goal, a continuously learning health system.
It's really impressive how those pieces fit together. But let's talk brass tacks. What does this actually look like in a hospital? How are these components actually making a tangible difference for patients, for clinicians right now?
Oh, we're definitely seeing real impact already. Take emergency department triage, for instance.
Okay.
AI agents can automatically analyze data from incoming ambulances, predict the severity, and rank them.
Before they even arrive.
Exactly. So this means an ICU bed can be getting prepped while the ambulance is still en route for a patient the AI flags as critical.
That must save time.
Huge amounts. The typical impact we see is around a 20% reduction in what's called door-to-treatment time. When seconds count, that's massive. Or think about post-acute care transitions, patients going home from the hospital.
Right, keeping them from coming back unnecessarily.
Exactly. So Triage AI can monitor data from wearables these patients might have, tracking vitals remotely. If it detects concerning trends, like a sudden spike in heart rate or drop in oxygen,
Flags it.
it automatically escalates an alert directly to their home care nurse. The outcome. We're seeing about 15% fewer preventable readmissions within 30 days, catching problems much earlier, and one more chronic disease programs, like, say, managing diabetes. If a patient's glucose levels, tracked maybe via a continuous monitor, spike beyond their personal thresholds and stay there, the system can trigger an automated message, maybe from an educational chatbot.
Offering advice or suggesting action.
Right. Immediate, tailored support. And studies show this can improve A1C control rates, that's a key long-term blood sugar measure, by up to 0.6% on average, which is clinically significant for diabetes management.
Those are really concrete, powerful examples. It's not just theoretical. Stepping back a bit, beyond those specific uses, what are the sort of broader system-wide benefits? What's the bigger impact these systems have?
Well, the benefits really stack up. First and foremost, as you'd hope, improve patient outcomes.
Right, the main goal.
Absolutely. Critically ill patients get seen faster, interventions happen sooner, survival rates improve. It can even boost a hospital's overall quality metrics and reputation. Then there's the accelerated response we talked about, getting critical alerts surfaced in, say, under 10 seconds versus
3 to 5 minutes manually, you said.
at least, sometimes longer if things are really chaotic.
Yeah.
That speed difference is just a game changer in emergencies. And importantly for the staff, there's Reduced alert fatigue.
Ah, yeah, I hear about that a lot. Too many beeps and buzzers.
Exactly. By filtering out the noise, the low-value stuff, the non-actionable alerts, clinicians might see something like 30% fewer notifications overall. That means they can focus their attention on the alerts that genuinely need action instead of being constantly interrupted by digital clutter. You also get consistent prioritization. The automated rules apply the same logic, the same criteria, 204-7. It removes the human variability that can creep into manual triage, especially under pressure.
Makes sense. More objective.
And finally, these systems provide scalable operations. They can handle sudden surges in patient volume like we saw during the pandemic, without necessarily needing a surge in staffing just for triage. The AI doesn't get overwhelmed in the same way.
Okay, the benefits seem incredibly strong. Faster, more consistent, less burnout for staff, better outcomes. But, so what does this all mean? For a hospital or a health system that says, okay, we need this, what's involved in actually implementing it? It sounds powerful, but I imagine bringing it to life isn't just plug and play. There must be challenges.
Oh, absolutely. It's definitely not plug and play. And there are definitely best practices you need to follow. Number one, really, is stakeholder alignment.
Getting everyone on board.
Exactly. You have to involve the clinicians, the doctors, the nurses, plus the IT folks and the compliance and legal teams right from the very beginning. They need to work together to define the priority rules, the workflows, how it fits into their actual day-to-day.
Because if they don't buy in or it doesn't fit their reality.
It just won't get used effectively. Or worse, it could create new problems. So that collaboration is key.
Makes total sense. You can't just impose this tech. What's another foundational piece?
Next up is a data quality audit. This is critical. You need to really map out where all the data is coming from, figure out how to handle missing values, deal with inconsistent coding or terminology before you even think about training the AI models.
Garbage in, garbage out, right?
Precisely. The AI is only ever going to be as good as the data it learns from, so you've got to get that foundation solid first. We also always strongly recommend to pilot and iterate. Don't try to boil the ocean and roll it out everywhere at once.
Start small.
Yeah. Pick one department, maybe the ICU or the ED, validate the system's thresholds there, work out the kinks, build confidence. Then you can think about expanding more broadly. You learn so much in that first focused rollout. And another vital element is keeping a human in the loop, meaning you absolutely must provide an easy way for clinicians to override the AI's decision if they disagree. Maybe flag an alert they think was misrouted or had the wrong priority.
So they still have ultimate control.
They have to. It builds trust. But it's also crucial because that feedback, hey, the AI got this one wrong, gets fed back into the system. It's part of that continuous learning loop, helping the AI get more accurate over time based on expert human judgment. And flowing from that, the final piece is continuous monitoring. This isn't a set it and forget it technology.
Right.
You need to be constantly tracking key performance metrics. How fast are alerts being handled? What's the false positive rate? Are the clinicians actually happy using it? And based on that data, you need to be prepared to adjust the models, maybe quarterly, maybe more often. It's an ongoing process of refinement.
Okay, those practices make sense. But even with those in place, I still imagine there are some pretty significant hurdles to clear. What are the really big challenges hospitals run into?
Yeah, there are definitely major challenges. Integration complexity is often number one.
Getting it to talk to all the old systems.
Exactly. Many hospitals have legacy systems, older software that weren't built with modern standards like APIs in mind. So getting the Triage AI to pull data from and push alerts to all these different, sometimes ancient systems often requires building custom bridges, custom adapters. It can be a real technical headache, like digital archaeology sometimes. Then there's the issue of explainability and trust. We touched on this.
The black box problem.
Right. Clinicians, quite rightly, aren't going to just blindly follow an AI recommendation, especially when the stakes are so high. They need to understand why the AI flagged this patient as high risk.
They need the reasoning.
They need clear why explanations presented alongside the alert. This is crucial for them to trust the system, but also to know when their own clinical judgment might warrant overriding it. That transparency is key. Regulatory compliance is another huge one. Healthcare is, understandably, heavily regulated.
And the PAN and all that.
Exactly. HIPAA in the US, GDPR in Europe, other regulations elsewhere. They impose really stringent requirements around data privacy and security. You need robust encryption for data everywhere when it's stored, when it's moving, plus detailed audit trails logging every single action the system takes. It's complex and absolutely non-negotiable.
A lot to manage. And what about fairness? Does bias ever creep in?
Ah, that's a critical point. Bias and fairness is a major challenge in ethical consideration.
This raises an important question.
It really does. There's a real risk that if the historical data used to train the AI reflects existing biases in care delivery, maybe certain demographic groups were historically under-triaged, the AI could learn and perpetuate those biases.
So it could actually make health disparities worse.
Potentially, yes. That's why it's absolutely essential to rigorously audit these models specifically for fairness. You need to check if the system performs differently for different patient groups based on race, gender, socioeconomic status, etc., and then actively work to mitigate any disparities found. It's an ongoing area of research and development.
Wow. Okay, so there's a lot to navigate on the implementation side. But assuming systems can overcome these hurdles, where is this technology headed? How do you see triage AI agents evolving beyond just sorting alerts? What's next?
Yeah, that's where it gets really exciting, I think. What's fascinating here is Triage AI is already starting to move beyond just being a sorting engine. It's evolving into more of a collaborative orchestrator within the wider healthcare AI landscape.
Orchestrator, what do you mean?
Well, instead of just telling you there's a problem, the next generation of agents will start to help solve it more proactively.
Okay, like how?
We're looking at things like proactive outreach agents. Imagine an agent monitoring a patient's data at home, and if their risk score starts creeping up, it doesn't just send an alert to a nurse, it might automatically schedule a telehealth check-in for the patient for later that day.
Huh, proactive intervention.
Exactly. Or think about care coordination agents. After a patient is discharged, the agent could automatically book their necessary follow-up appointments or even allocate home health nursing resources based on their assessed needs, ensuring that continuity of care doesn't fall through the cracks.
Streamlining the logistics.
Right. Taking that administrative burden off humans. And looking even bigger picture, we'll see population health analytics agents. These could mine months or years of anonymized triage data logs to spot trends, predict things like seasonal flu surges.
Ah, so predicting demand.
Exactly. Allowing hospitals and public health systems to anticipate resource needs like how many extra ICU beds they might need next winter weeks or months in advance. That kind of predictive power derived from triage patterns could be transformative for planning.
So, really, if I'm hearing you right, triage AI agents are becoming much more than just sorters. They're becoming this foundational piece, this cornerstone of a more intelligent, interconnected network of care, helping care teams focus on the actual patient care, not just the data sorting, by handling that rapid prioritization and routing.
That's it, precisely. It shifts the cognitive load. Instead of humans constantly reacting to incoming signals, the AI handles the initial prioritization based on data, freeing up clinicians to focus on the complex decision-making, the empathy, the hands-on care. It lets them practice medicine at the top of their license rather than being data administrators.
Okay, so wrapping this up,
hmm
if we connect this to the bigger picture, the value proposition seems pretty clear.
I think so. It really boils down to faster interventions when they matter most, significantly reducing the workload and burnout for clinicians, and driving consistently better, safer patient outcomes across the whole journey of care from the community into the hospital and back home again.
All driven by this real-time analysis and this constant learning loop.
Exactly. Making healthcare smarter, more adaptive, more responsive.
So here's something to leave you, our listeners, thinking about. We've talked a lot about triage AI within hospitals. But consider this. What could happen if this kind of intelligent triage wasn't just siloed in individual institutions, but integrated across an entire regional or even national healthcare system? Imagine the potential to predict and maybe even manage public health crises before they fully erupt. What might that interconnected predictive capability mean for your own future experiences with healthcare? Something to mull over.